The limitation of biomarker in general is applying it to practice, especially when we have complex high-throughput biomarkers that may not be easily reproducible in the community. So the one that we thought was the simplest biomarker was PD-L1. That's an immunohistochemistry test that you can apply on tissue. And now we know, after many years, that is not as simple as we think. Why? Because there are several antibodies, because the cutoff is different, because some folks may decide to look at this biomarker by the naked eyes, others have it automated. So if this simple biomarker is complex and doesn't apply to every therapy we give in renal cell cancer, for example, it's becoming less relevant when you combine PD-1, PD-L1, and a VEGF than when you use nivolumab, ipilimumab, which is IO. So if that's the case, imagine biomarkers that are way more complicated and may not be readily accessible, I think, to clinicians to change their clinical practice. So it remains an extremely interesting area to dig into. But again, the threshold for a biomarker, to make it, to change your practice and to change your clinical judgment is still not there yet.